first presenter yaar?
Hello, sir. Good morning.
Good morning, sir.
Good morning. Agency here. Audio clear, sir.
Clear இருக்குங்க சார். ஆடியோல கிளியரா இருக்குங்க சார்.
Okay. எத்தனை மணிக்கு சார்? 10:30 கரெக்டா?
10:30 சார். ஆக்சுவலி எக்ஸாக்ட் ஷெட்யூல். ஆக்சுவலி 10:15 எல்லாம் ஜாயின் பண்ணுவாங்க.
சரி. ஓகே. நான் ரெண்டையும் இது மியூட் பண்ணிரலாம்ல, மைக் மியூட் பண்ணிரலாம்ல.
மியூட் பண்ணி வச்சிருக்கேன் சார் ஆக்சுவலா.
மைக் மியூட் பண்ணி வீடியோ மட்டும் இருந்தா போதும்ல. வீடியோ தேவையில்லைனாலும் வீடியோ கட் பண்ணிடலாம். சரி.
ஓகே சார்.
Hello.
Sir, good morning, sir.
Yeah, good morning. Am I audible?
Yes, sir.
Okay, thanks. So the meeting starts at 10:30.
Yes, sir. 10:30, sir.
Okay. Is my screen visible? Can you see my screen?
Hello, everyone. Welcome to this session of APAN opening of APAN 53. Hello. Hello, Sandil.
Hello. Good morning, madam.
Good morning. Hello. Hello to Vajan Singh Hospital.
Yes, madam. Good morning, madam.
Good morning.
Good morning. Good morning. Good morning. Good morning. Good morning.
Hello, Kaushik.
Hi, madam.
Nice to see you. Taking part.
I'm fine.
Hello to Temtech. Can we start at? Can we start the session? Hello, Temtech, the organizers. Hello. Can we start the session?
Hello,
Yes, yes.
please start the session. Thank you.
Because the time is there, I think we can start the session on time. Good morning, everyone. Welcome to this session on teleophthalmology. Our session is using teleophthalmology to diagnose various ocular diseases. At this juncture, the government has brought in the guidelines, Telemedicine Guidelines 2020. Due to COVID and social distancing, telemedicine has become a very important part. The government wants to propagate, Indian government wants to propagate it. It helps in social distancing and helps in providing healthcare to the rural people as well as the elderly in their homes. In our session, we have very eminent speakers, Professor Dr. S. Natarajan, veterinary surgeon from Aditya Jyot Eye Hospital, which is a part of Agarwal's group of eye hospitals. He is also the president of Telemedicine Society of India. Dr. Kim, who is the vice president of Telemedicine Society of India, he is also a veterinary surgeon from Aravind Eye Care Eye Hospitals. Dr. Sendil, who is also a part of the Telemedicine Society of India, and he heads WellCare Systems, and he's brought in a business model in telemedicine. I am from Sankara Nethralaya. I am also part of the Telemedicine Society of India. So I would now request the first speaker to deliver his talk. Professor S. Natarajan, who is the president of Telemedicine Society of India, a well-known international veterinary surgeon, and part of Aditya Jyot group of eye hospitals, Bombay, which is now a part of Agarwal Eye Hospital. Over to you, sir, to deliver your lecture. This is a recorded thing because he's traveling. It's a recorded lecture.
Hello. Thanks to APAN for organizing this meeting. And I'll share my screen. Thanks to Dr. Kim, Dr. Sheila John for having me. So my talk is on diabetic retinopathy screening in India. I'm happy to say I was the president of All India Ophthalmic Society and currently president of Teleophthalmic Society of India, apart from Chief Clinical Services at Aditya Jyot Eye Hospital, Mumbai. So according to the International Diabetic Federation, India has 77 million diabetic, which will increase by 2030 and 2045. And the global prevalence also from 415 to, it will go to more than, I think, double. It's actually 45 million and 145 million and 450 million with diabetes living in the planet now. So we recommend primary checkup at the time of diagnosis in every person. So as we learned in the preventive and social medicine, prevention is better than cure, particularly in diabetic, particularly where diabetic, anybody with the diabetes may go blind. That's the reason this program. So I have created a public initiative video along with the International Advertising Association and All India Ophthalmic Society, where you will be seeing this, which was screened. The President of All India Ophthalmic Society, I would like to thank the International Advertising Agency for starting this competition for making a campaign on preventing diabetic blindness. And I also like to thank Allergan for the generous support to make this public initiative movie to create awareness on diabetic retinopathy and how to prevent diabetic blindness. So as I said, this is a screening through teleophthalmology to prevent diabetic blindness. Are you diabetic, hypertensive? Do you know you may go blind?
The world will forgive you, but will you forgive yourself? Diabetic blindness is preventable. If you're diabetic, you need a retina checkup to prevent vision loss.
So thanks to Allergan and International Advertising Agency. So my dream that eye care should reach every village in India to eliminate preventable blindness. First is to start with diabetic blind free India and using a smartphone to take good retina photographs. So this is where I promised as a President of All India, we have the Nobel laureate, the Kailash, who's a Nobel Prize winner for peace as a chief guest in the conference. I want to bow down to Saint Thiruvalluvar. அகர முதல எழுத்தெல்லாம் ஆதி பகவன் முதற்றே விளக்கு. A is a starting word for the English, and the same way the starting one, Dr. Vikas Mahatme, who's a Padma Shri, and Brigadier Dr. Watts, who was the commandant of AFMC Pune, now an MP from Haryana, whom I told them, you should work for ophthalmology too. We also met the then Health Minister of Health in Maharashtra. So I want to introduce this portable fundus cameras. I don't have any financial interest. It can be mounted on a suitable bike. And I wanted to show that it's a 30-second movie. He's a 10th standard fail boy. I call him the hero of our foundation. He just takes the camera in the backpack, and they can take a fantastic photograph of retina and send it to the either reading center. So with the ever increasing number of diabetics, a limited number of ophthalmologists available in India, we have about 30,000 ophthalmologists for 1.4 billion people. It is difficult to screen all diabetics, especially those living in remote locations. So the fundus cameras currently used in taking retina images are expensive and not portable. And the solution to this problem is to train people to take fundus image using a portable camera and use artificial intelligence to detect referable cases. That's what we have done with this boy, and we are doing this with the Bombay Municipal Corporation. So that need for ophthalmic surgeon for screening is minimized, and they can utilize their time to treat those who are actually in need. And this way we can get eye care to reach every village in India. And I know we have 647,750 villages. So the role of artificial intelligence, and artificial intelligence is likely be to the best or the worst thing to happen to humanity. It is up to us which one it's going to be. That's what Stephen Hawking has said. And we know we need more working hands, and we have to make use of minimally trained staff who are already available. We arm them with AI to bridge this gap. And I always like this definition, which is commonly not available. There is intelligence, which is the capacity to analyze, think, make a decision, and categorize. And that's what we ordinary Indians lack. So we can equip them with the AI, which involves training the computer to develop this capacity. And the computer is trained to accept retina pictures, and that's why it can refer only a referable diabetic retinopathy patient. Out of 100, maybe 5 will be required to send to the doctors. So integration of retinal photography and AI, an AI-based grading and diagnosis system for referable diabetic retinopathy, and performs the following procedure automatically. That is, the identify the retina features, classify image quality, classify the existence and severity of the disease, and based on deep learning technology. They're both Microsoft, Google, and now the Medios company along with Remedio are doing it. I don't have any financial interest. The general practitioners, primary care physicians, and all the healthcare givers can easily diagnose referable diabetic retinopathy using the simple and affordable innovation that is the potential to make a huge impact both on the disease, social, and economic dimensions. Advanced image processing capabilities allow clinicians to work even with low resolution funded images and relatively lower cost than the manual methods. Accuracy of about 90% according to the initial pilot, which improves as additional data are gathered. Highly scalable process with quick response time, and solution is extensible later for detection of glaucoma because the optic nerve head, that is the fundus picture, will have the optic nerve picture. Emerging healthcare technologies focus on reducing unnecessary visits to medical specialties, minimizing the overall cost of treatment, and optimizing the number of patients seen by each doctor. There is a disadvantage to anything, so we have to master the technology. A negative AI-based finding may give the patient a false sense of security about the totality of their eye status. Emerging evidence from the Joslin Diabetes Center shows that diabetic retinopathy lesions in the peripheral retina are highly predictive of which patient will develop proliferative diabetic retinopathy, the blinding form of the disease. So, in case there is a periphery, there may be a chance to miss it. But at least my idea as a ophthalmologist, where in villages no screening is done, at least you're taking a photograph of the optic disc and the macula, and then those 1 out of 10,000 may have the periphery which may be lost. But if this is not done, even the central retinopathy will be missed. And we are happy to inform you that our Aditya Jyoti Eye Hospital and Aditya Jyoti Foundation, now it's called the Kamala Sundaram Foundation, has published a first of its kind world project for the screening of diabetic retinopathy, use of semi-skilled health workers, and artificial intelligence deployed on a smartphone non-mydriatic retinal camera in the municipal dispensaries of the greater Mumbai. So the plan of action: screen, diagnose, and treat. So this is how we create a pre-camp awareness, assembly of diabetics, and capturing of the images and uploading, diagnosis by ophthalmologist or image grader or the AI. This is a Remedio fundus camera on the phone, which can be mounted on a suitable motorbike for transporting for screening purpose, can mounted on any table, and it is you can charge the mobile phone and the infrared device, and you can see this is capturing the retina photo with the smart camera, where we can also use anybody to train to use the smart camera. And this is a video which shows how this the president of All India. So the diagnostic accuracy of community-based retinopathy screening with an offline intelligence system on a smartphone, which was published in JAMA Ophthalmology in 2019. It was ranking number 5 in all the JAMA network articles of the year 2019. And it was the most well-read article. And this is on 26 January 2019, we did a community diabetic retinopathy screening in Dharavi, and you can see these are 649 diabetic patients were screened and 53 were diagnosed with diabetic retinopathy, and we came in the Guinness Book of Records, and we have treated them totally free of cost. And so this was again another article, extension of the study, use of offline AI in a smartphone-based fundus camera for community screening of diabetic retinopathy, published in the Indian Journal of Ophthalmology. And there's and then also we have done diabetic retinopathy awareness in association with multiple comorbidities with the insight from the Diamond study done by Dr. Kiran Shah, our full-time diabetologist. And so hence I want to say that early detection and treatment after screening can reduce the prevalence of diabetic retinopathy even in the remotest part of the country, and reduction in the economic burden among poor and illiterate people, because you can diagnose diabetes by doing a HbA1c test and then also doing a retina photograph, so that you also create an opportunity for a non-skilled worker to become a semi-skilled worker by doing this, and it will help to improve overall health of the population of India. So the next 3 decades will be the most technologically disruptive era in human history. Advances in artificial intelligence combined with radical breakthroughs in hardware will usher in an era that sounds like science fiction today. Devices will fade away, virtual environments will emerge, and super smart AI assistants will organize our lives and run our businesses and maybe the healthcare too. In this new world, our relationship with technology will change forever. We will both virtually and biologically merge together. And so I may coin this ABCD. You can take photograph by any boy or a girl who is illiterate, but they can use a smartphone. And that's why I'm adding a simple smartphone. Anybody can use this and take photograph, and then using this camera, the Remedio. And so I use this word, borrowed this from the movie. Anybody can dance, anybody can screen for diabetic retinopathy. So I made this program, screening through teleophthalmology to prevent diabetic blindness, Jot Se Jot Chalao. And we also have an MOU with the Municipal Corporation of Greater Mumbai. And we have made this all over India, thanks to AIMS, Tripura, Odisha, and Sankara Nethralaya Chennai, Maharashtra Ophthalmic Society, Nirmalai Hospital Chennai, Anilai Hospital Mumbai, Bangalore, Lions Club of Jamalpur, Seva Sadhan, Lions Club of Siliguri, Remedy of Bangalore, and this is again Rajanaika Chennai, Radhatri Nethralaya Chennai, then Foundation, Aditya Foundation in Mumbai, Maharashtra Ophthalmic President Dr. Diagnose Taswala, then this is again in National Society for Prevention of Blindness in Delhi, Newton Shah Hospital in Gujarat, Prabhu Desai Clinic in Pune, and this was again a retina care hospital, and this is NKP Salve Institute of Medical Sciences, LMH Road, and then also that was in Umesh Ravankar in Yavatmal. And this is Dr. Abdul Kalam, who came and encouraged our social workers and community health workers in Foundation for Picturing Satellite. He gave us the name. He inaugurated the van with the Forest camera there. So as I said, there's no financial interest. And this is a motorbike. You can see the CEO of the Forest, Mr. K. Chandrasekhar, along with Mr. D. Shivanandan, and who's a former Director General of Police, to inaugurate this along with my father and grandmother. So the points to remember is we can train and employ youth of India, even with minimal education and no experience in retina photography, to reach out to the same vision of millions. So, like Swami Vivekananda said, I want to strengthen the youth of India, and the same youth of India can be trained and employed so that we'll have a powerful youth, because India has 65% of population below the age of 35. And this particular technology can be independent of electricity and internet, because the fundus camera and the infrared device can be charged and taken in the motorbike and gone. And without internet, using the offline artificial intelligence, which is embedded in the mobile phone itself. So when you take a phone and embed the image in the mobile phone, it will tell you that whether to refer or not to refer. So you'll have a better chat time offered to the referred cases, timely treatment is preventing blindness, and join hands for this monumental revolution, fight against blindness from diabetes. So we can make India free of the burden of diabetic blindness. Teleophthalmology can show us the way. Eye care can reach every village via teleophthalmology and artificial intelligence, Kashmir to Kanyakumari, and Arunachal Pradesh to Kutch. So I thank Dr. Aishwarya, my executive Shubha, for making this presentation possible. And I thank my entire team and Teleophthalmic Society of India for this presentation. So I'll be happy to answer any questions. I'm sure Dr. Kim and others can answer the questions. And thank you once again for the opportunity.
Excellent lecture by Natarajan sir, President of Telemedicine Society of India. Any questions? If there are no questions, we'll go on to the next talk by Dr. Kim, a vitreoretinal surgeon from Aravind Eye Care, and also the Vice President of Telemedicine Society of India. Over to you, sir.
Thank you, Dr. Sheila. Can you see my slides?
Yeah, I can see your slides, sir.
Thank you for this opportunity to share our thoughts on what we do on telemedicine, especially in the primary care. So, I mean, this is a very familiar slide that we all see, where we know that globally there's a huge population, and most of them, 1/4 of them, are living in a country like India. So this poses a huge challenge for us. So you need to create access so that everybody can access care. So that means we need to strengthen our primary care. In most developing countries, the proven treatment are reaching only 20% of the people who actually need care. Even in the 20% who get care, a significant number of them actually present too late for treatment for any good outcomes to happen. And this is very common in many conditions, even in ocular conditions like AMD, diabetic retinopathy, refractive errors. People do come very late. This can be easily corrected if we can reach them early on. And this is very important. Our practice is usually very reactive, dealing with those who actually present to ourselves, and the rest who are out there who need care are not addressed. So bulk of this tertiary care essentially deals with the failures. If we can actually take care of them in the primary care, the number of patients reaching to the tertiary care will be much less, as in these chronic conditions like diabetic retinopathy, or even in injuries, corneal grafts. All these may be prevented if they can be addressed at the primary care level. But how to reach these for everybody in need, especially in developing countries like ours, which is scattered, most of them living in a rural population where access to care is less. So this is just to give a brief something about the background of Aravind Eye Care for those of people who are outside. It's a large eye care set of eye care hospitals, which has 7 tertiary hospitals dealing with about 1,000 to 2,000 patients a day. And we have 7 secondary care hospitals, which does cataract surgeries and primary surgeries. And then we have community eye clinics, and more importantly, the primary care centers. Today, we have about 95 of them spread over the state of Tamil Nadu, that is in South India. So at Aravind, we usually go into the community to screen patients. We set a team of doctors and nurses to go screen into the community, do a complete examination, including refraction, fundus examination, and advise them for surgery as needed, especially for cataract. Then they are brought to the hospital, surgery is done, and they are sent back. But we realized even after doing this enormous effort, we do about 14 to 15 camps every week. We are still reaching only 7% of those who need eye care in spite of such an effort. And those with rarer eye conditions are not being addressed through these methodology. So we transited from camps, though we continue to do camps. Now we have established what we call as vision centers or primary care centers. So this is to address the issue of access. We established what we call as primary eye care centers or vision centers, which are technology-enabled centers, which each of these vision centers covers a population of about 50,000 to 75,000, where there is no ophthalmologist available. These are permanent facilities, functions every weekday except Sundays, and these are equipped to provide a comprehensive eye examination done by a trained ophthalmic technician. So this provides primary eye care and referral services. This is like a hub and spoke model. For every tertiary hospital, we have multiple vision centers which are not very far off, about 50 to 100 kilometers range, where the patients, if need to be referred, can access the tertiary hospital as per the need. So what happens in these, the patient flow, where the patient registers just like they register in the hospital, and then the technician does a complete eye examination, including refraction, slit lamp examination, applanation, tonometry. Then they would do a dilated fundus exam, take pictures as needed, especially for diabetic patients, or like even anti-segment pictures are taken. We have an electronic medical record where all the entire data is uploaded. And as soon as that is done, they connect to the base hospital where one ophthalmologist is sitting managing about 7 or 8 such vision centers. So the ophthalmologist has access to this electronic medical records. They see the records, they see the images, then they talk to the technician and to the patient over a web conferencing so that the patient is assured that the data is being seen by an ophthalmologist. And then they prescribe glasses or medicines or advise them for further investigations like surgery or whatever. So even if they need glasses, the glasses are dispensed right there, medicines are given right there. And this happens for 6 days in a week except Sundays. So this is a typical vision center where a patient goes in, gets registers. So they pay about 20 rupees as a consultation fees, which is good for 3 visits or 3 months. The patient gets a complete eye examination by the ophthalmic technician. And then they do a BP height weight measurements. They do applanation tonometry. They would do a fundus examination. They use these cameras. Now we use a little sophisticated like the Topcon fundus cameras. And then this is a teleconference between the doctor in the base hospital who sees the reports and then advises the patient on further need, whatever. So the patient is given glasses or medicines as needed. Only those who need to be referred will be referred to the base hospital. It was surprising to see of all the 100 patients, only 10% of the patients need to be referred to the base hospital for further examination, such as for cataract surgery or diabetic retinopathy or glaucoma evaluation. So this seems to be the best last mile connectivity in any healthcare intervention. And this has access to care for the local patients 6 days a week. Since it's locally available, more patients who do not access care have been accessing care. And there is no dependence on any attenders to take them to a hospital in the city. There's a time and money saved. And most importantly, compliance to care is better or improved, especially for chronic diseases like diabetic retinopathy and glaucoma. We are able to follow up on these patients, and this ensures continuity of care. So we have about 93 to 95, today 95 centers. This is the data from the last year. We see about 2,500 cases or consultations are done every single day across all the 7 tertiary care hospitals. So this last year, because of the COVID, we had a little less number, but the recovery of the patients happened much faster in the vision centers than in the tertiary hospitals because the patients were able to access these hospitals, which are, these primary care centers, which are locally available. So we have electronic medical records and the patients are prescribed. Even diabetic retinopathy screening using artificial intelligence, we have fitted them with these algorithms, the fundus cameras there. Earlier, it was an ophthalmologist who were looking at the fundus images. Today, an AI tool acts as an aided tool, and when the ophthalmologist sees the image, there's already a report regarding the diabetic retinopathy. So going forward, we would be adding other algorithms, which makes it easier for the technician to advise the patients based on these algorithms, such as especially for conditions like diabetic retinopathy, for glaucoma and AMD. This has become a role model, and this has been scaled up even in as early as 2006. The vision centers, we started working on them since 2003. And when we started our first vision center, and in 2007, we worked with the government of Tripura, which is a state in Northeast, which really has access problem throughout. We established 40 telemedicine centers or vision centers. Even today, they are functioning, and this has become the model for the government to showcase in every place. So this, again, in other states like Chhattisgarh, Jharkhand, they have established vision centers with our help. Today, we are also putting up about 400 vision centers in Bangladesh. This is to be owned and run by the government of Bangladesh. Today, already there are about more than 90 vision centers which have been established, and the rest is being established over a period of time. And this will give access to eye care for almost throughout Pan Bangladesh. There is another model that is being experimented in our Chennai hospital, where we are what they call as, along with the Rotary Club, they are creating orange hybrid vision centers, which are small static vision centers along with mobile vision care units, such as in two-wheelers and in four-wheelers. This is started last year, and still we need to see how it is working over a period of time. Seems to be a good model to create access in the community, because the team is going into the community, and this will help the people who are immobile to access eye care. So what we have today is a very good national-wide broadband is available, so we are able to access care and give telemedicine care or tele-access to all these patients. And with different policies that are coming in, a good primary care system will reduce the bulk of load in the tertiary care. So we actually see in the tertiary care only those who really need tertiary care facilities. So doctors' time is very well engaged. So thank you for this opportunity. Thank you, Dr. Sheila John, for giving this. I'm happy to answer any questions that you may have in this.
Thank you, sir. Thank you for your excellent talk, sir. Any questions from the audience?
I guess it's too early or too much of ophthalmology to ask any questions.
There are many ophthalmologist institutes which have joined, sir.
Okay, good.
Vietnam and in India also. Anyway, there are no questions. We'll take together at the end. The next talk is by me. I'm from Sankara Nethralaya. I head the Teleophthalmology Department of Sankara Nethralaya. And we have been doing teleophthalmology since 2003. I'd like to share my presentation with you. It's basically, we do it in Tamil Nadu as well as in Calcutta, we have been implementing. My topic for today is comprehensive eye examination and telescreening in rural India. I'm part of Sankara Nethralaya, Chennai, Tamil Nadu. Now, healthcare availability in India, population of more than 138 crores resides in India. 80% of the population resides in rural areas. 70% of the healthcare resources are in urban areas. One ophthalmologist per 100,000 population. Indian Space Organization was the first to implement telemedicine in India. They provided the satellite dish, and they also implemented in many hospitals in India. In remote areas, only the VSAT of Indian Space Research Organization worked, as well as poor internet connectivity. We also, in Sankara Nethralaya, started a tele-mobile unit with the help of Indian Space Organization in 2003. And I would like to thank the Indian Space Organization for implementing teleophthalmology in Sankara Nethralaya. Here you see a mobile van with VSAT connectivity. This mobile van had a room where ophthalmic examination could be done, as well as teleconnectivity could be done. The disadvantage was, as there was only one room, only 30 to 40 patients could be seen at the single day. But this helped in remote villages where we did not have a hall or anything for the patients to get examined. Later in 2011, we switched on to a van which carried only the team members and the equipment. There was no room for design for patient examination. And we switched from VSAT, that is satellite connectivity, to internet connectivity. Although internet connectivity was improved, but it was not feasible in all the villages. If you see the manpower is mobile unit at campsite, we had optometrists, 4 optometrists, social workers about 3, drivers 1, optician 1, project officer, 1 project officer and 1 photographer. At the base hospital, we had a technical coordinator, information and technology person and the assigned ophthalmologist. Now we had electronic medical records in the villages. It was an offline thing. One of the laptops acted as a server. We had a Wi-Fi connectivity and we created a hotspot and connected to the other computers also. And you can see the optometrist feeding in the clinical examination as well as uploading the images. This was very useful because at each time of the visit, we could see the images and see the progress of the disease. Now, the ocular images, especially in diabetic retinopathy patients, we could identify the lesions and take it up for diabetic retinopathy screening. Presence or absence of diabetic retinopathy. If presence, refer to the hospital. Now, teleconsultations at the central hub, about 50 Mbps internet connectivity, high definition web camera was there, screen scaling of the images, and we had done soundproofing of the images. The ophthalmologist was seated at the base hospital. Now, virtual visit, the optometrist with the patient was at the campsite. The computer with data card with 2 Mbps internet speed. But in rural villages, internet speed was 120 to 650 kbps only. And our video conferencing software supported the bandwidth of 512 kbps. Now I would like to share a video of our camp where you can see all the ocular procedures.
Due to the COVID-19 pandemic, the eye camp activities have been restructured since March 2020 as per the Government of India guidelines. The COVID-19 protocols are strictly maintained in every camp in both rural and urban areas. One such camp was organized in the rural areas in Periyavayyavur, Kanjipuram district on 7th of August 2021. A middle school was chosen as the campsite after obtaining necessary approval from the local bodies. Our hospital staff went to the campsite along with the instruments, and necessary examination stations were organized. Patients at the campsite were required to wear a mask and to follow strict COVID-19 protocol. Patients are instructed to use hand sanitizer using an alcohol-based hand rub for 20 minutes and are seated in the patient's waiting area after ensuring adequate social distancing between patients. The patient's temperature is then checked and noted in the patient's identity card and are registered electronically in the EMR system along with the name, age and address and other demographic details. The optometrist then performs autorefractometer after wearing a mask and a face shield and after using a hand sanitizer. This is then followed by a detailed history taking after ensuring sufficient social distancing is maintained. The optometrist then tests the distance visual acuity after disinfecting the trial frame, occluder, or by asking the patient to close one eye after using hand sanitizer. The near vision chart is held by the optometrist instead of the patient after hand sanitization. Patients who cannot read charts in languages are tested using the illiterate e-chart. This is then followed by pupillary examination and examination of extraocular muscle movement. Patient spectacle power is then examined using a lensometer and the details are entered in the electronic medical record system. For the slit lamp examination, the patient's chin red and the forehead rests are cleaned and with the optometrist wearing a mask and a face shield, and the patient undergoes ocular examination. In case of any systemic diseases, the patients undergo undilated photography, and in the presence of any abnormal retinal findings, the patients are referred to the base hospital for further evaluation. Social distancing is maintained with only 5 patients in a room at a time. The teleconsultation is arranged between the patient, the optometrist at the campsite, with the teleophthalmologist at the base hospital. Patients' findings are then shared with the ophthalmologist through the electronic medical records, and the patient's consultation is improved with a real-time consultation with the ophthalmologist. The ophthalmologist examines the slit lamp and other photographs and provides further advice to the patients. The patients are then referred to counseling. Once the patient has been diagnosed with cataract or other ocular complications, the CAM coordinators or counselors provide referral and give clear instructions for patients. For patients requiring only a change in glasses, they are referred to the optical shop where their interpupillary measurement is taken. The patient is then presented with a choice of frames. Once finalized, the glasses are made and dispensed later at the village with the help of the donations. So this is a summary of the CAM statistics shown here. This CAM examined 70 patients. A majority of patients had refractive error and were advised spectacles based on the visual needs and requirements.
I've shared with you a video where all the ocular procedures are done by the optometrists and social workers at the campsite. In Tamil Nadu Mobile Unit, from April 2010 to January 2022, we had done more than 2,000 camps and more than 2 lakh patients were seen. Wherever in the very remote villages, internet connectivity was there, teleconsultations had been feasible. If you see the prevalence of the ocular diseases, majority were refractive errors, followed by cataract, then retinal diseases, diabetic retinopathy, and others. We also had a mobile refraction unit given to us by Ocular India Private Limited, which accompanied the teleophthalmology van, and glasses could be done at the doorsteps and delivered to the people. Here again, the spherical glasses could be done. High astigmatic power could not be done. I like to share a video of that.
ನನ್ನ ಹೆಸರು ನಂಜುಂಡಪ್ಪ. ನಾನು ದೇವನಲ್ಲಿರೋದು. ವಯಸ್ಸು 65. ಮಡಿಕೆ ಮಾಡ್ತೀರಿ. ಮಡಿಕೆ ಮಾಡ್ಕೊಂಡು ಮಾಡ್ಕೊತೀರಿ. ತಂದೆ ನದಿ ಕಣ್ಣು ನೋಡೋದಕ್ಕೆ ಎಲ್ಲ ಒಂದು ಇದಾಗ್ಬಿಡೋದು. ಏನೋ ಓದ್ಕೊಂಡ್ಬೇಕಾದ್ರೆ ಬರ್ಕೊಂಡ್ಬೇಕಾದ್ರೆ ಸಣ್ಣ ಕೆಲಸ ಮಾಡೋಕ್ಕಾದ್ರೆ ಎಲ್ಲ ಕಣ್ಬೀಳ್ತಾ ಇರಲಿಲ್ಲ, ಎಲ್ಲ ಜಾಮ್ ಆಗಿಬಿಡೋದು ಒಂದೇ ಸಲ. ಏನೋ ದೂರ ಇದ್ದರೆ ತೋರ್ಸ್ಕೊಂಡು ಬೀಳ್ತಾ ಇತ್ತು, ಹತ್ರ ಹೋಗಿದ್ರೆ ಏನು ಕಣ್ಬೀಳ್ತಾ ಇರಲಿಲ್ಲ. ಏನೋ ನೆನೆಸ್ಬೇಕಾದ್ರೂ ಹತ್ರ ನೋಡ್ಕೊಂಡ್ರೆ ಕನ್ನಡಕ ಇದ್ರೆ ತುಂಬ ದೂರ ಇದ್ದರೆ ಎಲ್ಲ ಒಂದು ಜಾಮ್ ಆಗುತ್ತದೆ, ಎಲ್ಲ ಒಂದು ಹೆಸರಿಗೆ ಹೋಗ್ಬಿಡ್ತದೆ.
It also has excellent trained manpower.
ಹಾಕೊಂಡ್ಮೇಲೆ ನಮ್ಮ ಜೀವನಕ್ಕೆ ನಮ್ಗೆ ಚೆನ್ನಾಗೈತೆ.
next slide. Eye care in remote areas. India is a country with diverse cultural heritage. The geographical location is a barrier in the diagnosis of ocular diseases. Now with these mobile vans, which is with paramedical staff, as well as equipment, we can go to the remote villages and examination of patients can be done. So the outreach teleophthalmology screening camp prevents visual loss, as that we are able to screen the patients. Now the comprehensive eye examination done by aided teleophthalmology camps by the optometrists, and it is aided by technology and it's shared with the ophthalmologists at the base hospital. This expertise made available cost-free in the villages and tribal areas help in eradicating blindness. Thank you very much. Any questions? If there are no questions, I'd like to invite the next speaker, Dr. Sendil, who has done a lot of work on diabetic retinopathy, and he is also a member of the Teleophthalmology Society of India. He has created a business model. So far, we have been talking about rural models and implemented in the villages and tertiary care. What this model is a business model which should be followed by everyone, because unless it's a business model, teleophthalmology cannot be done. Over to you, Sanjay.
Thank you, Dr. Sheila and APAN and Sankara Nethralaya for giving us the opportunity to talk today. Very interesting sessions before from Dr. Kim and Dr. Natarajan and Dr. Sheila John, which took us into the various types of teleophthalmology which are being practiced in India and by the different organizations. So what is more important, though we always say that there is a huge number of patients to be screened, and for example, let's take the example of India. We have around 75 million diabetic patients who needs to be screened for diabetic retinopathy on an annual basis. But what is important to reach to those number of patients is to have a very viable business model. I think teleophthalmology will scale only when we create financially viable business models where patient also pays and the doctors are the organizations which are running the teleophthalmology become profitable. That is when I think scale will happen and the real impact of teleophthalmology will also be known to the public and the patients and doctors. So over the next 10 minutes, I would touch upon various types of business models which are being followed by different organizations in teleophthalmology, not only from India, but from international also. So the common question is, how do we predict the future? So the best way to predict the future, as quoted by Peter Drucker, is to create it. So even for telemedicine and teleophthalmology, I feel that the best way to predict the future is to create a future for it. And the future can be created when we have very strong, solid, viable business models. So in India, there was something happened with the COVID 2 years back because telemedicine got recognized by the government of India, and the government of India issued a telemedicine practice guideline in 2020 after the COVID pandemic started. This made a lot of boost for all the telemedicine business, because there was always a question of whether what we were doing is legal in India. So because there was no rule which said it's illegal, but there was nothing to quote which said that telemedicine business model, so the practice of telemedicine itself was legal. So the telemedicine practice guidelines gave a huge boost once it was announced by the government of India, making everything legal, and gave a lot of push to the telemedicine businesses also. So what are the teleophthalmology models which are in existence today? So the first model is the direct to patient teleconsultation, where the patient can get into either a video call or any kind of an app and then talk to the doctor through teleconsult. But in ophthalmology, as you know, there are a lot of limitations in this kind of a model because ophthalmology is always requiring a lot of diagnosis. So it's not only what we talk to the patient like psychiatry or maybe like dermatology, but you also need to have the visual acuity checked. You also want to see the fundus. You want to see the anterior segment and a lot of.
Can I interrupt you for a minute?
Yes, madam. Yeah.
You're in the first slide. Are you moving the slides or you're talking only on the first slide?
Yeah, I'm moving the slide.
But, the movement is not there. That's why I just want to.
Okay, 1 minute.
The first slide will reach.
1 minute. Are you seeing the second slide now?
I'm seeing the second slide.
Okay, so I will put it in this way.
Yeah.
So I was in this slide, the direct to patient teleconsultation, where the patient
Full
can
screen.
get.
Again, 1 minute, full screen.
Actually, I don't know if it will move. So are you able to see the next slide?
Yeah, I'm able to see the next slide.
Okay, okay. Sorry about that. And the direct-to-patient teleconsultation has its own limitations because ophthalmology needs a lot of information about the anterior segment, the fundus, refractory status, the visual acuity, which we may not be able to have just by talking to the patient. I think this is one of the major limitation of video consultation alone with the patient, and this direct to patient teleconsultation might get improved as we have more and more home diagnostic devices, say where the patient can himself take the image of the fundus or take a picture of the anterior segment in a larger scale and send it to us. I think that will change the direct to patient teleconsultation business model. So what is more successful now is in B2B kind of a model where you have teleconsultation in a healthcare facility, where the patient visits an optometrist or a patient visits a general hospital or a diabetes center, which has all the equipments and instruments for doing the screening, just like you saw the vision center model of Arvind. So where a patient visits the vision center, which is equipped with all the instruments. There is somebody who can take the visual acuity, the anterior segment imaging is done, and then the doctor from the remote location connects to the patient. I think that is a very viable and successful model. Patient is also happy that is able to see the doctor online, and doctor is also happy to provide a more complete diagnosis and treatment solution to the patient. So the teleconsultation in healthcare facilities or vision centers or physician clinics is something which will really boom in the coming days. So I think we also saw from Dr. Sheila John's presentation about the initial teleconsultation where these mobile vans go into the villages or into the urban areas and screen patients, and these vans are connected by satellites before. Now with the internet connectivity becoming good. So this is a really good model, but cost effectiveness of this model and the willingness of the patients to pay is a question in this kind of a mobile model, because to run a larger van, the fuel cost, the road conditions, and then paying the driver, and then so patients in India, we have a problem that whenever these kind of vans go, patient always perceive it to be a free service. Patients don't want to pay for it. But there are some models where these kind of vans are equipped with retinal screening equipments, retinal diagnostic equipments, and they go to nearby eye hospitals where patients get screened and treated in these vans. That has become more viable than a regular teleconsultation kind of a thing alone on a mobile van. So this is the third model. And what I have been doing over the last, say, 7 years is diabetic retinopathy screening through teleophthalmology, where we work together with the diabetes centers or general physicians or even labs. And these centers are equipped with the fundus camera, an Indian camera called the 4S, just like Dr. Natarajan mentioned. So this camera is installed in a diabetes center, and then from this the staff in the center is trained to take the image, and images are uploaded into the platform which we have developed on our own, and the ophthalmologist can log into the cloud from anywhere and they can do the reporting. This is a very successful economically viable model because the physician, there is a doctor present in the physician clinic. Are you able to see my screen?
No.
Okay.
Slides are not.
Slides are there, but it's not moving.
Okay. So now I think you will be able to see. Just one. Can you see this diabetic retinopathy screening slide?
Yeah, I can see.
Okay, then I will not put it in full screen. So this is the diabetic retinopathy screening in association with physician centers, where fundus cameras put in a diabetes center, and then images from there are captured and uploaded into the designated platform. And from there, ophthalmologist, the well-care ophthalmologist can log in from anywhere and do the reporting. So this is a very viable model because the physician is benefited by providing a value-added service to the patient, and also there is a financial component to the physician, and then the reporting ophthalmologists get extra paid, and then as a company running the service, we also get paid for the service. I think this kind of a model is more viable. Patients are happy to pay because they get all the services under one roof, and they don't have to go again to an ophthalmologist, and only the patients who have issue are referred to the ophthalmologist. So that's the business model which I was talking about. The equipment is deployed, a non-mydriatic low-cost fundus camera is deployed in a diabetes center, and all the patients who go to the center get screened. The staff in the center themselves is trained to take the images, and these images are uploaded into the platform, and the doctors certified, and our doctors log in and they do the reporting, and the reports reach back the center within 30 minutes. So just like teleradiology, we have adapted this for teleophthalmology. So this is the third model. And another successful model which is really required is the retinopathy of prematurity screening, where low cost Indian cameras are employed, and in neonatal ICUs where ophthalmologists are not able to visit, and patients and the children or the babies born are screened for retinopathy of prematurity, just like how we were doing it for diabetic retinopathy for the adults. So this kind of a model is being practiced for children or babies. Very effective model. And apart from the above said models, now telemedicine is moving towards the kiosk kind of models, where patients, when they visit a trade fair or when they visit a mall, they would also like to have an eye checkup done. So Globe Check is a company which has designed this globe equipped with all the instruments like autorefractors, OCTs, and fundus camera, everything. So patients just go and rotate into the different components of the globe, and then there is a remote ophthalmologist to screen the patient and then gives the report within as quickly as possible. So this is another model which is coming up in a large scale. And there are a very simple vision check kiosks where patient can just walk in and then key in the information, and there is a refraction being done on a vision check, and they get a glass prescription based on the vision check through this kiosk. So Eyesight is another company which is into development of these vision check kiosks, which can be even deployed in pharmacies or labs and even general hospitals. So another important model emerging, particularly in countries like India, is teleoptometry, because we don't have these trained optometrists, and there are hundreds of thousands of optical shops all over India, which are run by semi-skilled professionals. So these professionals, if they are able to connect to a skilled optometrist through a central network, and then the devices in the clinic is controlled by a central optometrist, and the optometrist in the clinic does the basic evaluation, I think the value or the quality of the glass prescription becomes as good as possible. So teleoptometry is another emerging business model which is coming up in India and also abroad. So another, like all the patients now want to do it themselves. So just like patients want to check their BP, sugar, and all these things themselves, there are companies like IQ which has come with kind of do-it-yourself vision checks, The patient himself can get his objectively do his vision check and then send the refractory error prescription to an optician to get the glasses. So this model is also coming up in a large scale. Apart from the vision checks, I think there is a lot of emphasis on the online visual field testing. So patients who are glaucomatous, especially with the COVID scenario, patients are not able to go to doctors. So MRF, Melbourne Rapid Field Testing, is a company based out of Australia, where they give a software which the patient can download and use in his own home in the iPad and get a visual field testing. So this is also something which is new coming up in the field of teleophthalmology. I hope soon there might be other tests also coming up. There are lots of apps where patient can check the visual acuity, the macular analysis. All these things are done through some apps. So MRF is something which is coming up in a large scale. Melbourne and doctors are also supporting this. So what is more important, as I said, is the imaging devices. A lot of innovation has to happen in the anterior segment imaging devices and the fundus camera, so that these devices become cheap and easy to handle. Mostly if the patient themselves can take the images, that is when teleophthalmology will also see a boom. So there are phone-based fundus cameras, but the quality of images coming out of these cameras still are not up to the mark to do a diagnosis. Hopefully, when these phone-based cameras also become good quality, I'm sure a lot of business model innovation and scaling up will happen. So another thing which we cannot, when we talk about business models and teleophthalmology, we cannot downplay the role of artificial intelligence. So there are all these companies, right, from Google to IBM to Microsoft, everybody is working towards developing that perfect artificial intelligence to identify diabetic retinopathy or glaucoma. And I'm sure soon they will come out with a product which will enable the doctors to do better diagnosis. And the large number of people who are having this diabetic retinopathy all over the world, so will be immensely benefited. But this one thing which I want to emphasize is that these artificial intelligence should not work independent of the doctors, but they should be working in along with the doctors, and doctors should use it as a preliminary tool to screen, and then still patients should always be seen by an ophthalmologist. So both the systems should work together, the traditional medicine and the artificial intelligence. I think both of the systems should work hand in hand to screen and develop and reach as many patients as possible. So the FDA also permitted the artificial intelligence. That was a huge boom to the AI developers with the FDA, one company getting the FDA approval for the artificial analysis and intelligence algorithm. So there is a lot of work happening on machine learning, artificial intelligence, either for diabetic retinopathy or for ARMD glaucoma. I'm sure a lot of innovation will also happen in that scenario, and many companies are coming up in these models. So fundus camera innovation has to happen, as I mentioned. So we need to get low cost cameras, easy to use cameras, which will help teleophthalmology scale. So last 1 or 2 slides about our company. We are a leader in teleophthalmology services, where we work with diabetes centers, physicians, and labs. And our company is promoted by ophthalmologists, and we are almost present in 275 locations all over India and also in Ethiopia. And we reached out to 1.5 million patients since the inception, and every month we are now reaching out around 30,000-40,000 patients. And screen them for diabetic retinopathy through our methodology. So this is the impact we have created in one of our projects. And these are my contact information. I'd like to thank Sankara Nethralaya and APAN and Teleophthalmology Society of India for this opportunity. And I will be happy to take any questions if you have.
Any questions? Thank you for your excellent talk. Actually, teleophthalmology needs more business models so that the private practitioners and other ophthalmologists come forward to adopt it. And during the COVID times, it's the safest thing because social distancing can be maintained, as well as in the rural villages and old patients who have diabetes, diabetic screening also can be done. I would request the audience to come forward with any questions. If there are no further questions, I'd like to conclude the session. We had many people like Natarajan sir, Dr. Kim sir, and Sandhu, who have given excellent talks on the various aspects of teleophthalmology. I would thank the organizers for giving me this opportunity. Thank you, one and all. Thank you very much. Temtech, do you have any questions for me? Temtech?
No question. No question. Thank you.
Thank you. I have concluded the session.
Excuse me?
Yes?
I couldn't hear you. Can you say it again?
I have concluded the session. The talk is over. There were no questions because many of the participants, I can't see the video, so I'm not sure whether any questions are there. So I concluded the session. Anything for me to do? Any questions for me? Can I conclude the session?
No questions from Temtech. Please proceed.
Can you see a new engineer, Dinesh Murthy, who has taken the place of Mr. Gani?
Yeah.
This is Dinesh.
Thank you for your kind support.
Yeah, thank you.
The other person has been Pramila, who has also been coordinating. Hello.
Yeah, hello. Thank you always.
Thank you.
So sessions, and then all the discussion is over. You can close the session.
Yeah, I can close the session. Thank you.
Thank you very much.
Thank you all. Goodbye. Thank
Goodbye.
you.
Thank you very much.
Thank you.
Yeah, thank you. Thank you. Thank you very much.
Well, stay at home.
Thank you very much.
Kaushik.
Thank you, ma'am.
Thank you. Thank you, Kaushik.
Welcome, ma'am. It's a nice session. It's good, sir. Good, ma'am. Good, ma'am. Thank you. Thank you so much, ma'am.
Thank you.